they say that overnight success takes about 10 years, maybe even longer if you're an academic, longer still if different time zones are involved. So today, let me tell you about a unique international collaboration in supportive care that has flourished despite 9 hours time difference and a pandemic right in the middle of it. I'm Bogda Koczwara, and this is Supportive Care Matters. Today's conversation is sponsored by Canteen. My guests today, Associate Professor Lisa Beatty, a clinical psychologist and an expert in psycho-oncology from Flinders University in Adelaide, Australia, and Professor Nick Hulbert-Williams, a chartered psychologist and a health psychology researcher from Edge Hill University in Ormskirk in northwest England. Lisa and Nick, welcome to the show.
Thank you.
Thank you very much.
Perhaps we can start by asking both of you to tell me a little bit about your work separately, and maybe we could then talk about how your work intersects. So Lisa, do you want to start?
Sure. So my research broadly looks at developing alternative or more accessible ways of providing support to people with cancer, in particular focusing on digital mental health. We know that there are many people who need psychological assistance, and the availability of mental health clinicians that are trained in psycho-oncology are insufficient to meet the need and the demand out there. So over time, a lot of my research is really focused on providing evidence-based ways of meeting that need through different modalities, and most recently focusing on digital modalities for providing that support.
Very important in a country like Australia, where the distance is a major problem to care delivery.
Absolutely.
What about you, Nick?
Yeah, well, I've been doing cancer survivorship research for a long while now. Most of the work that I do is focusing on the psychological impact of cancer, both for patients and their support networks, thinking about how we can use psychological theories to understand who's at risk of problems like anxiety, depression, and then what interventions we can develop to address those and help improve the experience as much as we can for people affected by cancer.
So there is a lot of synergies about the work that you're doing, and indeed you have forged a very thriving collaboration. Despite the fact that you're positioned at the opposite ends of the world, there's about 9 hours time difference, and you spend a lot of your time working together right in the middle of the pandemic. So tell me a little bit about what your collaboration involves. How did it start, and where are you going with it?
So I might get us started with the description here. So I guess the collaboration, it goes back quite a few years now. It doesn't seem like that long. It still feels fairly fresh, and I think that's because we really enjoy working together. So it's not something that's dragged out. It feels like it's been very new still. But at the same time, when I look back, it goes back quite a number of years now. But basically what happened was I developed a program together with Bogda, actually, as part of my PhD. This is going back many years now. And then following the completion of my PhD, I was able to adapt this program to an online version of it, and it's called Finding My Way. And we rolled that out in the Australian setting as part of a big national funded trial. And then we got a lot of really good evidence to support that trial or that program, Finding My Way, in supporting people with cancer after they've been diagnosed with a curatively treated cancer. And around that time, we started looking at, there might be other adaptations that we can do for this program, and in particular looking at whether we could adapt it for women with metastatic breast cancer. And it was around that time that I first reached out to Nick around whether or not he would like to join the investigator team for the metastatic breast cancer adaptation of the program. And then from there, it took many years and many attempts to get funding for that project, but we have actually gone on to develop an adaptation of the program for women with metastatic breast cancer. And then parallel to that, then Nick approached me with his ideas. I might hand over to you, Nick, about where you headed with that.
Yeah, sure. So obviously I'd read all of Lisa's work kind of developing Finding My Way when I got involved with the metastatic adaptation. And I guess I realized that there might be some scope for trying that in the UK. We have a high level of unmet needs for psychological support here in the UK. So we thought, well, there's something ready prepared, ready packaged that we could potentially lift from Australia and try here in the UK. So we applied for some funding to do an adaptation and a replication trial, which is almost finished. That's our Finding My Way UK study, which comes to an end this summer.
So have you had a chance to look at any of your findings yet?
We've had a little look. We've looked at some preliminary data. I haven't looked at the 6-month follow-up yet, but we've looked at the 3-month. It's worked in terms of being acceptable. and people like it. People seem like they get a lot of benefit from it qualitatively. We're not finding so much in terms of our quantitative outcomes. And actually, that's because there isn't much distress. Our primary outcomes are distress reduction, but unusually for our sample, they're quite psychologically healthy. There's not much going on that we needed to fix in that regard, which is limited to an extent some of our findings. When we look at just those really distressed participants, we find the intervention is much more effective. But that's a slightly complicated statistical approach we're going to need to do to pull that apart, I think.
So it seems to me that this is really a good opportunity to compare not just the interventions, but the intervention effect in different settings, because you're dealing with different populations, different needs, perhaps different time of the intervention testing. Did you get a sense that the populations that you studied were similar or different between the two different countries, Australia and UK?
They're fairly similar. If we look at baseline depression, baseline quality of life, anxiety, those kind of things, there's actually not that much difference between them. One of the things I do wonder about, the big contextual difference, is that we recruited and we started this study during the pandemic. And I think that probably has made a really big difference. You kind of think that an online intervention would be perfect for in a pandemic because you can't do face-to-face interventions. But I think because everybody was so zoomed out, nobody wanted to really engage with any more online things. I wonder if that's had an effect. But also I think everybody was at home. Everybody was around their social support networks. Everybody had a lot more psychological support around them, which may have then reduced that baseline distress level that we expected to find, but didn't, which limited the outcomes.
You cannot imagine that we would have a discussion in 2023 and do not mention the pandemic as part of the research conduct. So it's interesting because in listening to you, it occurs to me that digital interventions, which is what you're studying, could be conceptualized from two different ways. One as a way of overcoming access barriers, and the other way is enabling self-management of patients. And it seems to me that even though at first glance this intervention is particularly useful at overcoming access barriers, perhaps the self-management needs might have been different because, first of all, people were self-managing better in the sort of context of their family supports being at home and not being allowed to go anywhere else. And also because their self-management needs perhaps also included things you couldn't fix, like concern about COVID and its implications. So such a phenomenal difference, even though your populations would be different. How did COVID impact on the actual logistics of running the trial? For example, recruiting or convincing clinicians to inform patients about the intervention. I would imagine that would have been a real challenge.
It was a challenge. I don't recommend starting a trial during a pandemic. So our grant for this study started literally the month that the UK went into lockdown. So that first 6-month period when we were supposed to be doing lots of video interviews to update the materials on the intervention was all when we were in absolute social lockdown. So that posed some challenges. So we delayed the start a little bit. We had about a 2-month window where social restrictions were lessened. So we very quickly got out there and did those interviews as quickly as we could, with some very high-level health and safety risk assessments in place. And then once we started recruiting, it was a lot slower than we expected. So we thought we'd recruit for this very quickly, given the population that we were reaching out to for recruitment. What we found is that eligibility was much lower at the early phases of recruitment, and I think that is probably related to the delays in getting people diagnosed and treated during the early phase of the pandemic meant that actually more people were at a more advanced stage of illness, so they weren't eligible to take part in the study. So that affected things early on. We had to bring on a lot more sites. So instead of having 4 hospitals, we ended up with 10 hospitals recruiting for us. So it all kind of expanded out because of those restrictions. Even when things were up and running back in hospitals again, there was problems with the nurses who were recruiting finding a private space to talk to patients about the trial because every room was being used to clear that backlog with clinical appointments. Even when they could find a space, the participants were still very much resistant to have a face-to-face conversation, so we had to switch some recruitment to being by telephone. It was definitely the most flexible I think I've ever had to be with adapting a trial iteratively along the way, I think.
And if I can just add to that, at the exact same time that you opened recruitment or opened the study for Finding My Way UK, we also opened the pilot study for Finding My Way Advanced for women with metastatic breast cancer. So we commenced recruiting for that on the 28th of February, and we went into, all the measures were implemented 2 weeks later here as well. So all the same issues that you're outlining, Nick, we experienced here in Australia to a certain degree too. But I would note it was probably slightly to a lesser degree. We didn't experience the same degree of lockdowns, but we did need to bring in that flexibility of how we're going to approach people, how we're going to reach them, slowed recruitment rates, the fact that for clinicians, it wasn't necessarily front and centre. During a pandemic, funnily enough, they were actually much more focused on clinical care, and it felt like anything to do with clinical trials dropped off the radar. It was prioritised lower, understandably so. So I think it did result in a much slower recruitment rate, which then has actually helped to inform us about what are the realistic expectations and targets for recruiting for these sorts of trials moving forward.
So it means that you both had to adapt significantly to the challenge of conducting a clinical trial in the middle of the COVID pandemic. What implications does it have for implementing your research findings into clinical practice or adapting it to evolution of future research, given that you were working in such extraordinary circumstances?
Good question, Bogda. One of the things that we've already heard is I do feel like in some ways people might be a little bit over the digital space.
Zoomed out?
A little bit zoomed out, absolutely. That I think even though this does address some of the accessibility and issues, I think COVID has really highlighted how much we seek connection. So maybe in terms of implementation, it's around potentially exploring ways of adding in that opportunity for connection as well, while also recognising that one size doesn't fit all, that this does meet the needs for some people, providing a purely self-managed version of a program. But I think it definitely does highlight to us that we need to factor in what is actually helpful for people at a particular point in time. And during a pandemic, it may not actually be the best time for doing remote or self-guided programs when they are actually desperate for connection. So it is around, I think, developing a range of and a suite of options for people, and they can kind of self-select what one suits them at that point.
I'd agree with that. I think there's the other sides that I think that we're thinking about, having reflected on our experience of running this trial, is that it's not just that it's not a one-size-fits-all, it's that some of the ways we traditionally recruit for some clinical trials may not work in the same way for these kind of interventions. So I think you're right that one of the big benefits from this kind of trial is not just accessibility issues, but it's helping to build those self-management skills. Those patients who are more motivated to build those skills might be more motivated to find these kind of interventions of their own accord. So actually trying to recruit via the clinical teams as we did may have meant that actually it's not the right time to do that for people to be approached for this trial. It might mean that there's some gatekeeping issues going on because they may not be advertising it to all the right people. It may be that in that clinical space, some people are so focused on the clinical issues that they can't even contemplate doing something psychosocial. So I don't think it's just a COVID issue, but I think it's made me think more broadly about what the best method is to advertise and recruit into a psychosocial trial.
And just to follow up on that, we, for the Finding My Way Advanced pilot, also recruited via social media. And I think it's worth just reflecting on the fact that it helped a lot in terms of getting the numbers up. And, I guess those that are keen on self-management were more likely to opt in through that pathway. But that doesn't necessarily mean that they're more likely to use the program in the way that it's intended or have any higher levels of engagement with the program, for example, compared to those that were recruited via clinicians in hospitals. And I think for some people, especially when you're working in the cancer space, knowing that a program has been endorsed by a clinician gives it a degree of credibility. Given there are so many resources that are developed out there, there's thousands of them that are developed by every Tom, Dick and Harry, that sometimes it's actually knowing that this one has been supported and endorsed by your practicing clinician can help to increase the trust in it. So I think it's a real balancing act between, on the one hand, there's the gatekeeping and then there's the prioritisation potentially of the physical side of care over the psychosocial. But on the other hand, if the clinicians do endorse it, it's going to potentially lead to more trust in the program.
And it may mean that it varies from setting to setting and the cancer type and stage of cancer. So COVID aside, it seems to me that there is quite a need for refinement and adaptation as you taking a digital intervention and use it in a particular context, whether it's a different country or different cancer type. And Lisa, you mentioned that both of you are working on the study for metastatic breast cancer, and I know that you've also had some collaborations around the world in adapting original Finding My Way to other country settings. Having that experience, what do you see are the sort of key steps in the process of adaptation in such a way that you can be confident that the content of the intervention actually fits the needs of the population you're applying it to?
I think the key thing I would highlight is you can't just assume that you can do a cut and paste job. You can't literally just roll it out as it is in the new setting, whether it's to a different population of people with cancer, like metastatic as opposed to early stage cancers, or if it's going to a different cultural context or to a different part of the world. So one of the latest ones that's about to actually get underway is adapting Finding My Way for people in New Zealand with hematological cancers. So it's going to a different cancer group and a different country at the same time. So I think it's about recognising that you need to do the groundwork in partnership with people. So you go through what's called a co-design process and make sure that those with the lived experience, those with relevant clinical experience as well, are involved in reviewing what's currently there, what we currently have, and what iterative changes we need to make it appropriate for the unique needs of that setting and that population.
So, Nick, you didn't do the cut and paste job. What did it actually involve for you to take the Australian intervention and adapt it to the UK setting?
So there were multiple phases. I think that the kind of co-design element that Lisa's talking about, we did a lot of that actually before we got the grant. So we worked with some of our patient partners to make sure that this was the right intervention, to get a sense of how much change would be needed. And actually the feedback that we got was that it does seem to do the job and that actually it would need fundamental changes, which is why we focused on this for our grant application. Once we then got the grant and we started reviewing page by page the content, thinking, okay, what references do we need to change to UK healthcare instead of Australian healthcare systems, where there was signposting to charities and different supports and helplines, all of that needed changing. We also did so there's video clips embedded into the intervention, both with healthcare professionals and with patients. So we recorded those. For the healthcare professionals, we had them as scripted as the Australian ones were. So we just videoed them so they were exactly the same. But the patient ones, we really wanted to get the kind of voice of our local population and their concerns. So we did between about an hour and 2 hour videos with 9 new patient representatives and then edited that down and replaced that content. We also spent a lot of time going through where there were references to evidence and evidence-based recommendations, because about 6 or 7 years had passed since Lisa put this original intervention together. We wanted to go through and make sure that evidence base was still the same. So we updated any advice and references that we needed to. And I think our final change that we had to make was we wanted to make sure that this website appealed to as broad a population as we could. And in the Northwest, we have a very varied demographic, both culturally, ethnically. So we wanted to broaden out the kind of perceived representability of the website. So some of the kind of cartoons, some of the photographs we switched out so that it would appeal to that broader demographic.
That sounds like a huge amount of work. Does that mean that every time you develop a digital intervention, we need to start from scratch, or is there a way of systematize that process?
I don't think you need to start from scratch. I mean, that development process for us took around about 5 months, but that was during COVID.
You had nothing else to do, really.
No, absolutely. But we were also doing a systematic review alongside it. So it was only kind of a portion of the work we were doing on the grant. So it was far less than, I think, developing something from scratch. And actually, I think what we've now got is something that works for the UK setting. So any adaptations that we now make in the UK, so I've had a chat with Lisa already about adapting this for patients with sarcoma. Actually, we've done the bulk of the changes in making it UK specific. So it would then be just tweaking for that population. So I think when you take it to a new country, there's probably an initial fairly substantial change. But then for different populations within that country, it's much more minor.
I can just imagine that the sarcoma program will be coming to Australia in the cancer centre near you.
We'll just keep swapping them over.
We will.
That's right. I think this is really growing very nicely. Now, seriously, this is just an example of an outstanding success that, of course, just happened overnight, just as pandemic started, right? So can I ask you to reflect on this success concept and the overnight success in particular? What made it so special? What made it easy? Was it hard? Am I to assume that it's easy? Can you talk about your relationship that is not just having a regular Zoom meeting, but what makes that type of collaboration special, aside from the fact that one of you will have to dial in very early and one of you will have to dial in very, very late?
I mean, obviously it didn't happen overnight. I think the key is willingness to work hard, and both of us have independently and together worked very hard on these projects. And I think it's also, this sounds corny, but I think there also has to be a lot of trust that, you know, this project, this program has been my baby since my PhD days. This is 17, 18 years of work for me that's gone into this. So any adaptations that happen, you know, I'm not protective of, but I you know, you want to make sure you're investing and handing it over to people. In people that you know are going to treat it with the same degree of care that you have put into it. And so, there's absolutely got to be trust both ways. You know, from Nick's point of view, I can imagine as well, when you're actually asking and putting a request into you, someone else's intervention, that they won't be being a gatekeeper of that either, that they're actually willing to let you do what you need to do to make it work in your setting. So, there has to be a lot of trust and commitment to making it work across countries and across time settings and everything else.
I think it's also about taking time to build that working relationship. I think the trust that's involved in a collaboration aside, because you need that on any project, I think when you are building these much longer lasting collaborations, you have to put the work into building that relationship. So I think we've taken any advantage, I think, that we can to build that. We've had lots of Zoom meetings, but also going to the same conferences where we can and taking the time to meet up at those conferences. I've been lucky enough to have a couple of trips over to Australia in the time we've been working together. So it's about timing my trips so that we've got some time to really develop that collaboration as well as the collaborative project, if you see what I mean.
Yeah, invest in the people, not just the project.
Indeed.
Absolutely.
Now, you both broadly work in the field of psycho-oncology, so taking perhaps a step back away from your specific specialized project, when you reflect at your career in supportive care in psycho-oncology, what are the main highlights for you and your career in that field? And are there any lowlights?
I think I'm going to start with the lowlights, and I'm doing this more in a very broad. I think you have to have a thick skin to be in, and this doesn't just apply to psycho-oncology and supportive care. I think this applies to any research, that you have to almost submit your work and submit your grant ideas expecting that they're not going to get funded, because that's the reality of the funding landscape at the moment, especially in Australia. And just to give psycho-oncology a little bit of a plug in supportive care, we are less likely to be funded than other areas as well. Like the rates of anything to do with mental health getting funded, and I'm hoping there might be a bit of a turning point about to happen in light of all of the COVID impact and funding kind of starting to come into mental health. But in general, psycho-oncology hasn't been well funded, so we don't have the same resources to back what we do. So you have to be willing to make, these trials work on next to nothing in terms of the funding at times. So you have to be, really be able to persevere in the face of adversity. But, isn't that exactly what we're asking of our patients and our people living with cancer as well? So I think that's probably the lowlights, is just the repeated, you've got a good idea, it's actually important and meaningful to people with lived experience of cancer, and just for whatever reason, it's not catching the research funding of the time. In terms of the highlights, when you do get the funding and when you do get the feedback from people who are using these programs, and that's probably the biggest highlight, to be honest, when you get these beautiful comments back from people who have used the program and have said how helpful it's been to them when they weren't able to access support anywhere else, that would be one of the key highlights. So forgetting all of the, the highs of getting the grants and whatnot, or getting that paper published, I think it's actually knowing the impact it's having for people on the ground is the biggest highlight for me.
I would absolutely agree with all of that. I think for me, the other low point, I guess, is often the problems we have with recruitment. I think When we're talking about cancer, we think these studies are going to be easy because the diagnosis rates are so high. This is such a big population. We think that this will be easy research to do. And certainly I think early career researchers often come along thinking that. But actually, recruitment is incredibly challenging, both logistically and finding the right time that people are going to say, yes, I've got the brain space and the emotional space to do these kind of studies. So that's probably the low point for me, that a lot of my studies have really struggled with recruitment. I think the other high point for me, I think Lisa's right, that the impact side is a real highlight. But I think the other side for me is that it's a great community to work in. I think I have, over the course of my career, I've transitioned between a few different academic communities. I've worked in the health psychology community here in the UK. I've worked in the psychosocial oncology community more broadly. I've done some work in the kind of contextual behavioral science group and the societies that belong with that. And I think of all of them, psycho-oncology is, I think, the most friendly of those groups to work with. I often, when I'm mentoring early career researchers, I say I could try and prepare them that actually working in this field can be quite isolating. It can be, there's a lot of competition as a researcher. You're often working with people, as we've done in different countries. It's very rare that you're going to work closely with people in your university. So actually it can feel quite lonely. It can feel quite isolating sometimes. But actually the psycho-oncology community, I think, is quite special in that it just has a different feel to it. And I think for me, that's the real highlight, is being part of that community.
Can I also just add, there's a little phrase that I'll often tell my students in relation to the recruitment saga that you were just mentioning, is that just as a general rule of thumb, it takes twice as long to recruit half the number you were originally planning. So it's just worth keeping that in mind. And that's just the reality. If you go in expecting that, it can soften the blow.
Yes, managing expectations.
And that's on a good day.
That's on a good day. But you're absolutely right. It's the people as well. It's the people that we do this work for, and it's the people that we do this work with that make the difference.
I think it's an amazing symmetry of this overnight success story that two researchers who specialize in digital technology actually mention relationships so much, both in terms of the intervention that is delivered through technology, but also in the special ingredient that makes their work so worthwhile. So I really think that your insights will be incredibly useful to many other researchers who might be listening, and very, very inspiring in hopefully encouraging others to work in this field. So as we're coming to the end of the podcast, I'd like to finish off by asking you of the final question that I would pose to all the guests, and that is, what is your top reason why supportive care matters?
I think it matters because cancer isn't going away. I think we're making great leaps and bounds in how we treat cancer, and it is undoubtedly going to change. I think I've got, hopefully, a good while of my career left. I don't think in that time the psychological impact of cancer is going to minimize. No matter how many innovative treatments and how many changes we make to healthcare delivery, there's always going to be that kind of psychological, that existential impact, both for patients and their broader support networks. And I think that's why it matters, because this is a big life transition. And with any life transition, there's a psychological impact. So whilst cancer is here, there is always going to be that need for better supportive care. And I don't see that need going away anytime soon.
I completely agree with you there, Nick. And I think it's also that case that we may keep developing better and better treatments that either extend life or cure cancer, but it's about what's in that life. How can we make the quality of that life as best as possible, and for our patients and for their loved ones as well. So I think that's why supportive care matters, that so often we get fixated on, is this particular new treatment going to work? And I think the question sometimes we have to ask is, even if making the assumption that it does work, how can we make our patients' lives as full and as enjoyable so that they can live it to the max in the way that they would like to? So yeah, trying to reduce the impact of these treatments on their lives as well.
And you both certainly play a big role in that. Thank you very much for joining me tonight.
You're welcome.
Thank you.
Thank you for the invite.
Thank you for the invitation.
Okay, and over and out. That is all for Supportive Care Matters, a podcast created by me, Bogda Koczwara, for researchers, clinicians, policymakers, and patients passionate about improving the lives of people affected by cancer. Thanks to Mark Tai, who composed the original music, The Oncology Network, our producers, and Canteen, our sponsors. For show notes, go to www.oncologynews.com.au, subscribe to this podcast at your favorite podcast provider, and rate us. It will help others find us.